All right, I think we'll get started now. Good morning. My name is Jazine Alders, and I'm a research coordinator with the McMaster Institute of Research on Aging. Thank you for taking the time to join us. We have a few tips for getting the most out of the seminar today. If you haven't already switched your Zoom view to speaker view, we encourage you to do so. On your Zoom screen in the top right-hand corner, you should see an icon. If the wording under the icon says gallery view, click on the icon once, and this should change it to speaker view. If for some reason you were not muted upon entry, we ask that you mute yourself to eliminate any background noise or feedback during the presentation. I would also like to alert you to the chat icon at the bottom of the Zoom screen. If a question or comment occurs to you during the presentation portion of the seminar, we ask that you please type the question or comment in the chat box, and we will review these during the question and answer portion of the seminar. Please note that this meeting is being recorded. I would like to begin this webinar by recognizing and acknowledging that McMaster University is located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. The McMaster Institute for Research on Aging has developed a reputation for its ability to facilitate connections between McMaster researchers across all 6 faculties, thus driving interdisciplinary research. Since MIRA launched in 2016, we have hosted multiple in-person events and exercises to facilitate interdisciplinary connections, as well as connections with national and international partner institutions. Continuing in this tradition, today we will be crossing faculties at McMaster University to discuss intergenerational trauma and life course. Our first speaker, Dr. Amy Montour, is a Haudenosaunee physician from the 6 Nations of the Grand River Territory. She's completed a Bachelor of Science in Nursing, Master of Science in Nursing, and Doctor of Medicine degrees at McMaster University. Amy works clinically as a palliative care physician and as an advocate for Indigenous health. She is also an assistant professor in the Department of Family Medicine and site director for the Grand Erie 6 Nations Family Medicine Residency Site at McMaster University. Our second speaker, Dr. Andrea Gonzalez, is an associate professor in the Department of Psychiatry and Behavioural Neurosciences with cross appointments in the Department of Psychology, the Neuroscience Graduate Program, and the Department of Health Research Methods, Evidence, and Impact at McMaster University. Andrea is also a core member of the Offord Center for Child Studies. She's an editorial board member for the journal Archives of Women's Mental Health, Child Abuse and Neglect and Child Maltreatment, and holds a Tier 2 Canada Research Chair in Family Health and Preventive Interventions. I will now turn the time over to our first speaker, Dr. Amy Montour.
Good morning, Sego, Scano, Ani. Hello to everyone, and I'm excited to be a part of this speaker series. I'm hoping to give you a bit of a quantitative view of intergenerational trauma that will complement Dr. Gonzalez's presentation as well. So every Indigenous culture has a similar principle in that we look forward and backwards in terms of our responsibilities. All the decisions that I make today are based on the wisdom and knowledge that was passed down to me from generations of my ancestors before me. And every decision that I make today must be with the thought of 7 generations, all that came before me and all that will come after me. So I'm thinking today of my great-great-grandchildren and what the world will be like for them. And that is part of why I do this work, because I want the world that my great-great-grandchildren to live in to not have systemic racism against Indigenous people. And I want to break that cycle of intergenerational trauma that my people have been living in. So the Haudenosaunee here on the left have described it in words, and we're respecting the world because we're just borrowing it from everyone that's going to come behind us. And all of our cultural practices, our knowledge, and who we are as Indigenous people are very important in that principle of 7 generations. And I've given you an example, a pictorial example of the Mi'kmaq, who also have that similar idea in mind when they're thinking of how decisions are made. Now, the problem all started a long time ago. This is the Two Row Wampum, and it is the original agreement between the Haudenosaunee and initially the Dutch, but it was later opened up to to encompass more of the newcomers to Turtle Island, or what is known as North America. And this original agreement was basically the guidelines for our relationship. The wampum that you see before you represents a river or a body of water, and the white stripes are the foundations of our relationship, which should be peace, respect, and friendship. And the two purple lines indicate a European ship or a newcomer ship and a canoe. And we were always meant to be equals. We were always meant to be brothers. And we were to travel down the waters of life together, always trying to help each other, but never jumping into each other's vessels and trying to steer each other's ships. The problem between Indigenous people and non-Indigenous people is really the breakdown of this relationship. And that's what has led to intergenerational trauma. So we're going to use a case study today to try and understand how that breakdown happened and what it looks like for the person who is encountering healthcare or health services today. I have changed details and names, and there's no identifying information in this story, but it does have its basis in truth. And it's really about an elderly woman who was in great health, and one day she had a fall. And she fell backwards and she hit her head, and she had multiple bleeds within her brain and skull fractures. And at the hospital, her daughter was very clear that the woman's wish was to be full code, that everything was to be done to save this woman's life. But in the middle of the night, the family physician attached to this family got a frantic call from the daughter, who said that the healthcare team was torturing the patient and the family, and they felt like they needed to take their mother home, whether it was medically a good idea or not. So how did this situation come to be? And actually, it started hundreds of years ago. When we think about Indigenous health nowadays, we often hear a deficit story. What I like to term the poor sick Indian, higher rates of chronic disease, higher rates of cancer, higher rates of mortality. And the literature, the health research literature, is replete in these types of studies. But actually, for Indigenous people, the disease started a long time ago, when legislation and policy were made to control Indigenous people and to not honor the Two Row Wampum relationship that we had agreed to. And because of policy and legislation, we ended up with things like the Indian Act, which is a piece of legislation still in use today that governs all First Nations people. We were relocated to reserves, and the whole uh, intention of policy and legislation at the beginning of Canada as a country was to assimilate us. And when you take a group of people and you legislate how they can be, how they can dress, how they can look, where they can live, how they can speak, then you automatically other them. And when you other somebody, that leads to racism and social exclusion. And when people realize that they are not wanted wherever they are, then it has an impact on their self-esteem. And quite honestly, policy and legislation has been aimed at taking away the self-determination of Indigenous people. And without self-determination for our people, for our families, for our nations, then we are impacted in all determinants of health. Just a little deeper dive into the Indian Act. It had broad control in 1876 over our land, our property, our behavior, our spiritual practice, and our freedoms. Amendments over the next 50 years became even more restrictive. In with that, we could no longer carry out our ceremonies, our spiritual practices. We were relocated even from reserves where we had been relocated. If a town grew up too close by to us, we weren't allowed to dress the way we wanted to. And when we realized that we needed to start using the Canadian system to try and regain our rights, we were also banned from legal representation. From 1948 to 1960, there were more amendments, and these ones were actually lessening the restrictions. We were able again to practice some of our ceremonies and our spiritual beliefs. Unfortunately, because of the long history of oppression, still to this day, all of our ceremonies and spiritual beliefs and our practices and our ways of knowing are not in wide use. It is still something that we as Indigenous people today are trying to regain. What the early Canadians saw was an Indian problem. And we hear all the time about statues, about rewriting history, about people having opinions about the early leaders of Canada. And I'm not here to point fingers or to blame, but am here to just acknowledge that when the average Canadian thinks about Sir John A. Macdonald, they have one sort of perspective of them. But when Indigenous people think about Sir John A. Macdonald, this sticks out in your mind. And this is a quote from him. When the school is on the reserve, the child lives with its parents who are savages. He is surrounded by savages, and though he may learn to read and write, his habits and training and mode of thought are Indian. He is simply a savage who can read and write. It has been strong pressed on myself as the head of the department that Indian children should be withdrawn as much as possible from the parental influence, and the only way to do that would be to put them in central training industrial schools where they will acquire the habits and modes and thoughts of white men. And from that ideology became residential schools. And I'm not going to spend a lot of time speaking about residential schools. The Truth and Reconciliation Commission is out there. This film from the National Film Board of Canada, We Were Children, there is a ton of information out there on residential schools. And what we know from that experience over a century of assimilation policies in the schools, that what came out of that were significant educational, health, and income disparities for Indigenous people, racist attitudes, a loss of language. I myself don't speak my language, and a disproportionate apprehension of children into the welfare system. After residential schools were no longer compulsory, there is another phenomenon that many people don't know about called the 60 scoop. And that was really the start of children being just funneled into the child welfare system, into the foster care system, and away from their communities. And some of these children never experienced residential school, but they had this similar experience in that they were taken out of their culture, they lost their language and their connection to their peoples. And from all of that, we now see a disproportionate imprisonment and victimization of Indigenous people. So again, we'll come back to the concept of self-determination. And sometimes when I put this slide up, people feel that it is sort of aggressive in some way, but it is not meant to be aggressive. This is a statement from the Chiefs of Ontario. And it is not meant to be a war cry. It's not meant to be aggressive. This is simply who we have always said we were from before the touchdown of newcomers to North America to now. We are the Anishinaabe, the Mushkegowuk, the Ongwahole, and the Lenape peoples, sovereign nations of Turtle Islands. We have jurisdiction to administer our own political, legal, economic, social, and cultural systems. And as sovereign nations, we have never surrendered our rights or title in the right of the Crown or the successor state of Canada. And what that means is that although Canada now exists and the US exists, we have always existed in this land. Our people, our ceremonies, our knowledge, our culture has always existed here. And although portions and pockets of our communities have lost this knowledge, we are working on reclaiming that knowledge. And despite what political boundaries exist today, we still see ourselves as these people. My traditional homeland is actually in the Finger Lakes region of New York, but this was always shared land. We had an agreement with the Anishinaabe, which was mentioned in the land acknowledgement, which was a dish with one spoon, to share Southern Ontario as Indigenous nations because it was bountiful and we wanted to share our resources. So we still live under our history, our own rules, our own agreements with each other, despite the boundaries that have been overlaid by the formation of Canada and the US. From that policy and legislation came the systemic effects of the disease, which are the intermittent social determinants of health. And these can be found in our healthcare systems, our education systems, our community systems, in how we view the environment and in cultural continuity. I often put this picture up of this status card because a lot of folks who are just in the general Canadian population don't realize that we're still called Indians by the federal government as First Nations people. We are still given a number, and it is the federal government who is deciding who is First First Nations and who is not, which is directly against us and a way that we control our membership as sovereign nations. And because of that loss of control over every piece of our lives, our healthcare systems have been built as if we have no control over our lives. Our education systems were built that way, which is why in university, many of us have not heard the true history of Indigenous people in this country, because the education system was not built to tell the truth about Indigenous people. And in our community infrastructure, most on-reserve communities, their municipal structures such as water, uh, roads, sewers, all of those types of structures are grossly underfunded compared to non-Indigenous communities in this country. So the system has been built still with the idea that we need to assimilate, and if we don't assimilate, then we will be marginalized. And every part of the system is built that way. Some folks are not aware that there was a whole separate hospital system for Indigenous people, which was called Indian hospitals, and these operated for 60 years in the 1900s. And these were not culturally competent organizations. These were places where substandard care happened, where it wasn't the best and the brightest healthcare professionals who were maintaining services in these places. They were underfunded, and these places were not regulated. People were allowed to experiment on Indigenous bodies as if they were not human, as if they were mice, as if they were animals. And somewhere along the line, the narrative became that tuberculosis was an Indian disease, when in fact tuberculosis did not exist in North America before we had newcomers come to this country. But the idea in Canada was to protect the European people from the Indian tuberculosis, and that was the impetus for Indian hospitals. We were also dehumanized through health research. In residential school and in Indian hospitals, our children were experimented on. And in these experiments that included children, these children were often malnourished because residential schools, they didn't, and Indian hospitals had no intention of giving us the best of what could be there. It was actually what would the minimum to keep us alive. And the researchers came in, they did their studies, they realized what poor condition that the children were in, and they didn't do a thing about it. They didn't advocate for them. They didn't stop the study and say, let's focus on nutrition here and get these folks healthy. No, they just completed their studies. So we were dehumanized in health research as well. And when you dehumanize people, when you other people, you embed stereotypes. And for as long as I can remember, there has been a deficit-based narrative for Indigenous people, that we are sick, that we are poor, that we are less intelligent, that we cannot make a change on our own. And that kind of ideology embeds stigmatization and stereotypes. And Indigenous health research has been in the past very much built on that deficit-based narrative. Sorry. And what happens when you have systems that are based on false ideology, on ideology that that discriminates against people, is you have very real consequences. And this year or last year, we've seen that in the death of Joyce Echaquan. Indigenous women have been marginalized by policy, by legislation. My people, the Haudenosaunee, were matriarchal people. Our women held great importance in our society. But over time, because we have been assimilated by European notions, the role of our women was changed. And because we were strong women who weren't afraid to voice our opinions, somehow we became hypersexualized, and that had to be controlled as well. And there are very specific controls within the Indian Act and its amendment to control women in particular. And finally, we see the result of that in that Indigenous women in Canada are not valued. And that's why we have murdered and missing Indigenous women. And that's why a scenario like what happened to Joyce Echaquan is still possible in this country. And once you get through the policy and the legislation that underpins the systems, then you actually get to the symptoms of the disease. And these is what we're most commonly heard of in news articles and in our health research. Yes, Indigenous people often live in desperate conditions. So many communities in Canada do not have clean drinking water. We have mercury poisoning water in grassy narrows for 40 years that has not been remediated yet. We have substandard building codes, and we have contractors who have not been held accountable for what they have done under government contract on reserves. And this has led to insufficient, overcrowded housing. Many of our people have migrated into urban centers looking for something better. But as we know, it's very difficult to survive in an urban center, and this has led to oftentimes homelessness for our people. And when you are marginalized and you don't see yourself in the education system, you don't often strive for higher education. And if in this world, if you're not educated, if you don't have an undergraduate degree, it's very difficult to make a living that will provide for you and your family. And that leads to food insecurity. So Indigenous people, because of several hundred years of policy legislation that has been built into systems, are now suffering the effects of that, and they live in a chronic stress state. And this is really transgenerational transmission of historical trauma. A nation that has been politically disempowered affects a community, and that community affects and is affected by the breakdown of families. And without that family, that kinship support that is so critical to Indigenous communities, individuals find themselves lost. And that situation is perpetuated over and over and over again because uh, we haven't been given the tools or the freedom to break the cycle. But now our folks they've been given the tools by their elders, by their reclamation of cultural knowledge, by their reclamation of pride of who they are and what they can do. So if you're going to connect the dots, I like you to start with Maslow's hierarchy of needs, because most people understand that as a very basic concept of what a human being needs to do well in life. And if we overlay the social determinants of health on there, we can see that the distal determinants of health, the policy and the legislation, has always been a barrier to self-actualization and esteem needs for Indigenous people because it broke apart cultural and family connections and took away self-determination. The intermediate determinants of health, the systems that we function in, they continue to other us so that we don't belong and we don't feel loved by our fellow Canadian citizens. And that impacts our safety and security every day in life. And that is informed by a legacy of residential schools and those embedded stereotypes that lead to overt and covert racism, and a lack of cultural safety in the system, as well as I said, the societal norm that is a view of Indigenous people as being less than. And then we get to the proximal determinants of health, which are just those basic needs by which we need to function every day in life. And so when you think about the deficit narrative, what we've lost is the ability to understand all of those distal, intermediate, and proximal determinants of health. We want to focus up here where we want people to be healthy and screening for cancer and doing preventative health care. But if we are not providing the fundamental pieces beneath self-actualization where people can draw on their resiliency factors, then we are not giving people the tools they need to move forward and to break those cycles of intergenerational trauma. So when the Indigenous physician came to the floor, what they found was nurses who were very upset, who felt like the family was not respecting hospital policy or letting them do their job. But what the family said, every one of the large group along that around the family's bed was children of this person, and this person was speaking in their mother tongue, an Indigenous language. And what they were sharing with us was that this person was once again in their delirium, a 5-year-old child in residential school being held down and being abused. And they didn't want anybody near their mother because they were protecting them. So the factors influencing Leona and her family are trauma from residential school, which is a legacy of policy and legislation. It's also hospital visitor policies that don't take into consideration Indigenous families that are large and very connected, restraints policies that have nothing to do with an Indigenous viewpoint, and the mistrust of the Western system that has been embedded through Indian hospitals, residential schools, and health research. And then we get to the perception. This family had been asked so many times, how much had this woman drank that day? And she was not, she never drank alcohol in her life. But the perception was because she was First Nations, somebody had to be lying. This woman had to have been drinking. So the resolution of this case called for much more than writing a prescription. We had to change the setting for this woman. We removed all the restraints. The folks who in the room who could speak her mother tongue spoke to her and soothed her and reassured her in her mother tongue. And then she needed to be treated for pain because no one had treated her pain. Education was provided to the nursing team because they didn't realize that those were all this person's children in the room. It wasn't unnecessary visitors. They were all children of the patient. There was education about the legacy of abuse in residential school and the role of historical factors that led to mistrust of the system. And then there was education back to the family and support to them about why the nurses made the rules they did, because they were bound by the policies of their organization. And then there was advocating for change. Something needs to change because the substitute decision-making process in this province does not fit Indigenous people. So the Law Commission has been engaged to look at how can that be changed. And the hospital itself has been engaged to look at how can policies be changed. And so now I'm going to come out of this and stop sharing my screen and turn it over to Dr. Gonzalez.
Thank you. So can everyone see my slides then? So thank you, Amy, for such a powerful presentation. So I'm going to pick up on a few of the threads from Dr. Montour's talk about proximal and distal factors that are related to the health of an individual by putting it within a socio-ecological framework, and in particular, Bronfenbrenner's theoretical framework. So Dr. Montour talked about how really there are multiple levels within society that impact on the health and well-being and development of an individual. So Bronfenbrenner said that all of these levels sort of impact on an individual. And in particular, Dr. Montour was talking about political, historical, and cultural factors that have influenced Indigenous people over the years. That there's systemic changes that have been made due to policy and legislation that has created trauma within individuals. For my presentation, I'm going to focus more on the microsystem, so looking at family factors that impact individuals, and in particular, looking at adverse childhood experiences. So in the late 1990s, Feletti et al. Conducted a seminal study where they looked at adverse childhood experiences. And in particular, they defined ACEs as 10 events occurring in an individual's life. And this included physical, emotional, and sexual abuse, physical and emotional neglect, and various factors that they labeled as household dysfunction. So parental mental illness, maternal exposure to intimate partner violence, divorce or separation, incarceration of a relative, and substance use. And these were just individual questions that had a binary yes/no response that were sort of summed and calculated for individuals to have their ACEs score that ranged from 0 to 10. And what they found in this seminal study was that ACEs were quite prevalent in the US population, and that they were related to a whole host of negative outcomes. So work that was done using the Canadian Longitudinal Study of Aging by a fabulous postdoctoral fellow shared by Parminder, Reina, and myself, looked at ACEs within the CLSA. And what we found were very similar types of statistics. So this is a sort of complicated graph here. But what we found was that if you look along the x-axis here, it's the types of ACEs that we measured in the CLSA. So we measured physical abuse, sexual abuse, emotional abuse, neglect, exposure to intimate partner violence, death of a parent, parental separation or divorce, and then living with a family member with mental health problems. And we divided the CLSA population up into various cohorts based on the individual's ages. And what you can see is that the most common form of ACEs are physical abuse, emotional abuse, and exposure to intimate partner violence. And in most cases, there's a trend where younger cohorts, so the 45 to 54-year-olds and the 55 to 64-year-olds, are reporting higher prevalences of these types of abuse compared to the older cohorts. And then neglect here is relatively low, with under 10% across the board reporting childhood neglect. And this is the first study that actually measured multiple ACEs in the Canadian population. There have been other studies that have looked at different types of maltreatment, but no study to date that we know of has measured all of these ACEs in a single population. So when we added the total ACEs score in the CLSA population, what we found was that it did vary by sex and by age, but overall, 38% of the sample was reporting no adverse childhood experiences, 26% was reporting 1, about 15% was reporting 2, and then you see that there's a gradual decline here, with 9.4% reporting 3 and 5.6% reporting 4 or more. And this is a very common type of trajectory across the ACEs worldwide, so that you see that generally speaking, about 2/3 of individuals are reporting 1 or more ACEs across their lifespan. So what does this mean in terms of health? As the number of ACEs accumulate in a single individual, there's a pattern that holds, that's called the dose-response relationship, that shows that as the number of ACEs increase in a single individual, the risk for negative health outcomes also increases. And that there's some sort of tipping point around this 4 or more ACEs, where the increased risk for negative health outcomes actually increases exponentially. And we know that these negative outcomes are apparent across the lifespan. So numerous studies have looked at the impact of ACEs from childhood to old age, and they find that ACEs in early childhood is related to increased risk of injury, attachment difficulties, growth, and developmental delays. In early childhood and adolescence, it's related to mental health disorders and increased risk-taking behavior, and greater involvement with the juvenile justice system and some physical health outcomes. And then later in adulthood, it's related to an increased risk of mental and physical health outcomes, as well as challenges parenting your own children, which is related to the intergenerational transmission of risk, increased risk of chronic diseases, and obesity. There was a meta-analysis that was done in 2017 by Karen Hughes. And what they found is, looking across 37 studies, which represented over 200,000 individuals, and over 40 outcomes, what they found was that individuals with at least 4 or more ACEs were at an increased risk of all health outcomes compared to individuals who reported no ACEs. However, the degree of the strength of the relationship between ACEs and outcome really depended on what the outcome was. So what they found was weak to modest associations for things like physical inactivity or obesity and diabetes, with odds ratios less than 2. They found moderate associations between ACEs and smoking and substance use, or cancer and heart rate, so that individuals with 4 or more ACEs were at a 2 to 3 increased risk of having these disorders. The relationship between ACEs was strong between sexual risk-taking and mental health and problematic alcohol use, and it was strongest with problematic drug use and exposure to intimate partner violence or self-directed violence, with odds ratios over 7. So flipping the lifespan sort of into a framework. This is a framework that's been developed by the Center for Disease Control, really showing how these impairments sort of build on themselves across the lifespan. So adverse childhood experiences are related to social, emotional, and cognitive difficulties in childhood, which may lead to the adoption of health risk behaviors, which subsequently lead to disease, disability, and social problems, and increased mortality and morbidity later in life. However, they do recognize that there are scientific gaps between these different levels, and we call that the black box. So if we unpack the black box linking ACEs to health outcomes, what is it that is linking all of these early childhood experiences to such diverse outcomes later on? And what people have argued, and mainly Bruce McEwen and Clyde Hertzman, is that these sort of childhood experiences get under the skin to change physiology and to change our stress system and the way we respond to stress. It can lead to changes in brain functioning and to epigenetic modifications. That's been studied more recently. For the purposes of today's presentation, I'm going to just focus on this stress system. So our stress system, our stress activates the hypothalamic-pituitary-adrenal axis, which is then involved in the release of norepinephrine and cortisol. And it stimulates multiple body areas and our immune system, so that in response to stress, we actually do something about it. It activates our ability to kind of the flight or flight kind of syndrome. However, it also has a negative feedback loop that shuts the system off. So once we've sort of dealt with the stress, whether it's presenting to a group on Zoom or encountering some kind of wild animal, you know, we don't need our stress system to be turned on anymore, and it goes through various loops to turn the system off. However, if you're exposed to chronic stress or chronic childhood adversity, or through these systemic and long-standing types of stressors in our society, what it does is it triggers a constant state of arousal in our body and a heightened state of alertness and fearfulness of one's safety. So you never really feel that you're safe and that you should be shutting your system down. So our HPA axis never completely gets shut down, and your brain is being bathed in cortisol all the time, which is actually a toxic substance for our brain. And what this does is it leads to these high levels of stress hormones that are constantly circulating in our system. It leads to decreased regulation of the stress system, which I'll talk about a little bit more on the next slide. And it has a cascading effect on our other systems. So it leads to changes in immune system functioning, cellular changes in the brain, and changes in epigenetics or gene expression. So Bruce McEwen came up with his allostatic sort of theory of allostatic load. And what happens is when we get stressed, our body responds in a natural way, which is all the red arrows here. So it responds to the stress in a way it should, but it returns back to the set point. So there's a homeostatic recovery, which are these blue arrows here. But what happens is if the stress is chronically repeated over time, or never really shuts down, it actually alters our set point to deal with that stress. And that's what he called allostatic load, is that our set point has been altered, and we're now in a pathological state because of the constant stressors that we're experiencing. So theoretically, there is this model about how childhood experiences are related to health outcomes, and that it occurs through allostatic load, or these changes in terms of our physiology and our biology. But this has never really been tested empirically. So again, using the CLSA data, we wanted to test this model empirically. So using the comprehensive cohort, we created an allostatic load that was made up of multiple biological markers. And we looked at white blood cells, markers of diabetes, markers of immune function, markers that were related to kidney function and to cardiovascular function. We looked at cholesterol levels, blood pressure, and body mass index and weight to circumference and waist to hip ratio. So all of these markers were summed into an allostatic load index. And then we were interested in how that was related to multimorbidity. And in particular, we looked at 21 different chronic conditions. And again, these conditions were summed into an index. So again, this was work that was led by Divya, and I'm not going to focus on the social engagement piece of it. We did look at social engagement as an additional mediator, which was assessed by combining social support and social participation measures. But for the focus of today's presentation, I want to focus on allostatic load. So what we saw was that ACEs was directly related to multimorbidity. So as the number of ACEs increased, the number of chronic conditions reported also increased. And allostatic load was also independently related to multimorbidity. Not surprising that if they had more of those kind of allostatic indicators, it was related to more chronic conditions as well. But what we found here that was really the most important, or the neatest part of it, was that allostatic load mediated the association between ACEs and multimorbidity. So we kind of showed statistically and quantitatively that that whole theory that Clyde Hertzman and Bruce McEwen put forth a number of years ago was actually valid and true, at least in this sample. Another interesting thing that I just wanted to point out in relation to this study was that the direct and indirect effects of ACEs on multimorbidity was stronger in the younger age group and weakened with increasing age. So if you can see the first red box here in the 45 to 54-year-olds, we saw that that association between ACEs and multimorbidity was stronger, and that indirect effect was also stronger. And that it was significant in the younger age group, but was not significant. And this, I think, gives further evidence to the idea of biological embedding, that you could see how allostatic load was playing such a strong effect, and an important effect in the association in the younger age group. In terms of intergenerational effects, I'm not going to talk very much about it. We know that multiple things are transmitted across generations. Dr. Montour talked about it in her part of the presentation, but mental health, social status, education, social positioning are all transmitted across generations. And there is a genetic component to it, but what we're finding through animal work and more recently with human work is that there's a biological component to it as well that is not related to genetics. So for example, our team has studied cortisol levels between parents and children, and we found associations which could be genetically, could be an effect of genetics. But what we found was that more sensitive mothers had a stronger association between their cortisol levels and their child's levels as well. And then there's been evidence through Rachel Yehuda's work with survivors of the Holocaust that have also shown this transmission effect of biological systems and factors that is not related to genetics, but has more of an environmental component to it as well. So taking it back to Dr. Montour's presentation, how might this be relevant in a Canadian context? I think that Dr. Montour gave beautiful illustrations and examples of really the trauma that has been that Indigenous people have experienced through the systemic oppression and the different laws and policies and legislation over the years that continue to this very day. But there's only been one study to date that has shown how it might impact the next generation. And this was actually done by Christine Hackett at McMaster University. And what they did was using the 2012 Aboriginal Peoples Survey, they looked at the association between previous generational family residential school involvement and a number of health outcomes in the next generation. And what they found was that residential school generation in the parents associated with lower self-perceived health and increased risk of suicide attempts in the next generation. So it can, you know, this is again, another example of how these traumas carry across generations and affect outcomes of the next generation. So I just wanted to talk very briefly about the ecology of resilience, and that, you know, not everyone that experiences childhood trauma has negative outcomes, and that we have to think about protective factors that can occur at various levels. And at the microsystem level, the most important level is the family, but we also know that schools and neighbors and peers can have a positive effect. At the mesosystem level, we want to connect systems and microsystems. So how well do caregivers communicate with schools and different neighborhood and community services? And then speaking to Dr. Montour's point, we have to be really changing our social ideology at our exosystem and our macrosystem level, and be changing our laws and really responding to things like the Truth and Reconciliation report in order to make real change happen. So finally, what are some of the implications for policy and interventions as we move forward? We really need interventions that make resources available for at-risk families and their children. Preventative as early as possible, so high quality daycare, school readiness programs, wraparound services for families. And we need to take a trauma and violence informed care approach through what SAMHSA calls the 4 R's. So realizing, recognizing, responding, and resisting family violence. And that's it for me. Thank you.
Thank you, Dr. Montour and Dr. Gonzalez. We have a question from Vivian Underdown. She asked, was the study looking at the CLSA and the ACEs just looking at averages at different ages? Is there also demographic data, such as the difference between Indigenous people and others?
So yes, there is. We didn't analyze. We looked at a variety of socio-demographic factors as well as things like ethnicity. We didn't look at Aboriginals versus non-Aboriginals in particular, but we did look at ethnic minorities versus not in the CLSA. And I think, and Divya, correct me if I'm wrong here, CLSA, oh, Parminder's raising his hand, so I think he also wants to talk. So.
Why don't you finish your thought, and because it's an important point, so I can sort of talk about what the CLSA policy is around this issue.
Okay, why don't you do that then?
Yeah. I think that's an important question, whether we looked at the Indigenous versus non-Indigenous. First of all, the way the CLSA was designed, it randomly picked and people self-identified themselves as Indigenous. We did not go into particular Indigenous communities because that requires a very different way of doing research. And we didn't want to presume that the way the CLSA was designed will address the questions of those communities. And we had proposed to CIHR that they should actually be creating an Indigenous cohort that is led by Indigenous communities. Nothing much has come out of it, but that was the suggestion. Secondly, we have a few thousand people self-identified as Indigenous in the CLSA. And we made a very conscious decision that if we are going to look at those data, that should be looked under the data governance of the Indigenous community. So we've been having lots of conversation with those groups to see how do we look at those data, because if we had just presented this data, that would have reinforced some of the comments Dr. Montour raised about deficits. That's all we would have labeled in the context of this particular analysis. So we have actually right now not released any of the Indigenous data for any analysis in the CLSA till we sort out what the governance and the interpretation of those data mean and what implications that has for the community. So that's one of the reasons we did not present those data in here. Secondly, it doesn't represent all the Indigenous people in Canada. It represents a particular segment of the population that might be very different than the larger community. So that's why we didn't tread on that path at this point in time. But I would be delighted to have Dr. Montour involved in some of our discussions going forward. How do we, there's some important information, but how do we glean that information that doesn't further stigmatize the community that doesn't need that anymore?
Thank you, Parminder. Andrea, did you have anything to add?
No, I think
Okay,
Parminder
great.
was very articulate in answering that. He represented our decision-making process, so thank you.
We have a comment and a question from Marla Beauchamp. Thank you both for a very interesting presentation. I was curious whether there has been work to look at age at which experience the ACE and association with health outcomes.
So I can take, are you talking about within the same sample or like within the same population, like when it starts to occur?
Marla?
Hi, no, I mean, can you hear me?
Yeah.
Yep.
Oh, great. Age, like, so if you showed data to show, looking at the effect, how it dissipates over age, and how it's stronger and younger. And I'm wondering at what age a child would experience the ACE, if does that impact the outcome, the association with health outcomes? Like, are there critical windows of ages?
Yeah, so that's an excellent question. I mean, our data, and a lot of data actually in the field, does not collect like age of occurrence of the actual ACE, and in many cases they don't collect sort of chronicity or frequency. But what's unique about the CLSA study as well that I didn't get into was that our questions were much more in depth than the typical kinds of ACEs questions that Folletti and others in the field use. So we did have standardized measures to kind of get at that severity issue. But there was a recent paper by Dan Belsky in the US that showed that really the earlier that the ACEs occur, that the longer lasting impact that they actually have. But that's the only paper that I know of that has shown that.
Okay, thanks.
Andrea, but if the underlying hypothesis is from social embedding or biological embedding, There is lots of data from non-ACEs literature, especially the work from people like Clyde Hertzman or Chris Powers, have shown that the embedding happens quite early in life. Now, depending on what the compensatory mechanism might be available to these children through the life course, might have a different trajectory. But generally, it impacts, it gets embedded. Earlier it happens, more embedding it shows biologically or socially. Not only that, some people have speculated, and hard to get those data and very hard to carry out those studies, is that in fact, that the conversation that Dr. Montour started and you finished, that there might be actually more stronger intergenerational influence. So grandmother's experience might have much bigger impact on the grandchild because the biological embedding has happened over a generation that actually creates a trajectory that is really harmful. And that's what we heard from Amy in relation to this intergenerational trauma, how devastating that can be than a single generation trauma. Not that that single generation trauma is less important, it just embeds over generations and continues the cascade. So Marla, your question, do we have a lot of empirical data on that? Probably not, but theoretical animal studies do indicate that it probably has a stronger impact earlier or from an intergenerational perspective. That's why we want to start an intergenerational cohort as part of the MIRA to start looking at some of those questions.
Yeah, that's really interesting.
Dr. Montour, I wanted to ask you, how do we break this cycle? Is it possible to change these trajectories? We listed a number of implications for social policy and interventions. What do you think the most pressing needs are right now that we can address?
Well, definitely education. Until we're all sort of on the same page and have the same understanding of the entire history that has happened in this country, then I feel like my non-Indigenous colleagues are at a disadvantage to really truly understand the issues. But the other part of it is really, I think, resetting the relationship. The Two Row Wampum is still a living agreement. And the Haudenosaunee, the Indigenous people of North America, they still want to enter into that relationship. And so it's really at an individual level, an organizational level, and at a national level saying, we need to reset this relationship and let's do that. Dr. Reina, acknowledged that in the research they identified that we cannot move forward because if we do move forward in the way that we always have, if we continue with status quo, we are going to contribute to a deficit-based perspective of Indigenous people. That in itself is a huge understanding of stopping the cycle. And so we need more people like Dr. Reina and Dr. Gonzalez to say, you know what, we need to do the right thing. And if that takes more time, if that means that we have to invent a new way to do things or to look at problems in a new way, then let's do that. Let's think outside of the box because status quo for Indigenous people is not adequate.
Thank you. This has been extremely educational for me. I'm really grateful, Dr. Gonzalez and Dr. Montour, that you took the time to enlighten us on these topics today. And we want to thank all of our participants in the webinar today. If you have additional questions, you can always email us at mirainfo@mcmaster.ca and we will direct them to Dr. Montour or Dr. Gonzalez. And in closing, we invite you to join the McMaster School of Rehabilitation Science and MIRA for a webinar entitled How Can Clinicians Implement Canada's New 24-Hour Movement Guidelines for Adults, which is taking place on January 27th at noon via Zoom. Thank you everyone for your time and have a great start to your day.
Thank you so much.